Welcome back, everyone, to Vox Markets. My name is Paul Hill. I'm delighted again to be able to speak to Sara Barrington, CEO of Verici DX, a leading developer of immunodiagnostics that are used to help patients in their treatment for pre and post kidney transplant care. So welcome, Sara.
Thanks for having me. Great to be here.
Yeah, well, big congrats on yesterday's positive data release for Tuteva. But before we sort of dig into the details, I don't suppose you'd quickly remind investors of what the test aims to do and how it scientifically goes about doing so.
Yeah, absolutely. So we use RNA signatures, and what that is it's very early and highly dynamic information. So what the test is designed to do, and it answers the clinical question of is there damage happening or likely to happen, and is the body able to cope with it? So this is very unlike any other test on the market right now, because it's highly dynamic. And what that does is, at a very early stage, it warns clinicians that they need to get in to help that patient. And I think that that's a very important point, that it's an early indication. In healthcare, as you know, the golden rule is always earlier is better. Other tests will tell a clinician that damage has happened, so that's post the event. And of course, there's still stuff they can do and they can help it getting even worse, but damage has happened. This test is designed to be ahead of the curve and give clinician very valuable information at the time when they need it the most.
And just to give people a bit of color on that, so just take a sort of like an example. Let's just say, for instance, I'm a patient. I've just received my kidney, etc., and I've got a immune system that is sort of like, you know, a bit dodgy. Actually, in reality, it's not too far from the truth anyway. So I've just received this, and with my immune system, it doesn't like this foreign part, or it may not like it. Does that mean then that, say, if my immune system starts to attack it, does it give the doctor an earlier read on whether damage may occur? And if it does, then you can basically tailor my immunosuppressant drugs to effectively the therapy. Is something like that?
Yeah, it is very similar to that. And it's not just the immune system. You know, our signature covers that as a biological system, but also about cell repair, cell metabolism, right. Because, you know, your body can cope with, you know, internal attacks. And the clinician needs to be able to discriminate when they need to intervene and when the body's got it. So, you know, inflammation is one of your first indications that something's happening. It can pick that up. The clinician can read the signature. It says, okay, the body's not going to be able to deal with it without assistance. And then you would intervene with a therapeutic, either an immunosuppressant or with additional steroid treatments, etc. But they have a raft of options open to them. They just need them to know whether to employ them or not. Each one of them comes with a cost. That's always the thing with a drug medication. So both the clinician and the patient need to know that it's worthwhile. And this test will tell them, yes, it's worthwhile. You need to intervene.
So essentially then, compared to the sort of like, you know, other sort of diagnostics on the market, I mean, so you've basically got Tuteva, which gives you an early warning system about the potential damage that could occur. But the existing tests, etc., they work off identifying when the damage has occurred in the blood. So rather than actually something to attack it, so they're picking up something which is a later effect after the immune sort of response.
Yeah, and don't forget, it's highly non-specific. So I've always said, it's like measuring the debris in the blood after the carnage has happened. Right?
That's the existing products, you mean? Yeah,
that's right. The cell-free DNA products, those are the major existing products. They are also trying to those companies are also trying to roll out, you know, earlier tests like we are, not to the same levels of performance at all. So we've got a clear advantage there. But the cell-free DNA is, first of all, it's like the debris, so after the carnage. And secondly, it's highly non-specific. And this is not an area where you want to be non-specific. For example, they can pick up if, for example, there's been a passing infection. Let's take the BK virus. actually, if you've had the BVK virus, the clinician needs to reduce your immunosuppressant therapy regime, not increase it. But the results would tend to say, okay, there's damage happening, you need to increase the dosing. So they've known for a while that this is a bit of a confounder. And so not only is it later, but it's highly non-specific, and you need to be, it's what we call a PPV story rather than an MPV story.
Right. Okay. And so, yeah. Okay. And to give an analogy, which would be sort of topical, but it's sort of like your test, the Tuteva is a radar. It tells you when something's coming in that you want to avoid. Whereas sort of like an existing test is when the thing has hit you and you've blown up and you've got debris, you know, sort of like, right. So you get it way before to take evasive action. Whereas their test tells you where there's real damage happened, after the event. So just moving on then. So what's the sort of, just briefly, what's the sort of size of this addressable market? I mean, I know it's obviously significant.
Yeah, I mean, we've put it into the billions. I've seen a range from all sorts of companies on that market sizing. We like to point to just the size of revenues that we've seen, and where we can distinguish it. You know, obviously some of the larger companies, it's amalgamated into their consolidated results. But we did point to a competitor that's a little bit more isolated, and we think that after 5 years, they had about 200 million of revenue in the kidney space. I can't verify that exactly, but that was our estimate from reading their statements. So obviously for a pre-revenue company, that's a very attractive market for us.
Okay. And just in terms, I know you can't say too much in terms of the commercial sensitivity, but just to sort of like, what for investors, what sort of like scale of sort of performance improvement is the Tuteva above sort of like, the existing products? We've talked about, obviously, it gives you much better gives the clinician, the doctor, much better information to act before the damage has occurred. So that's great. But then just on the sort of the PPV, or the positive predictive value, can you just give us a bit of flavor on to sort of like what the accuracy comparative is?
Let's be geek it, right? Love acronyms. No one understands them. Right. So MPV, negative predictive value. And I, in previous life, I did a prostate cancer company. And that's where MPV is really used. It's what we call the rule out test.
Yeah.
So if you think, like in prostate cancer, it's very benign. Most men die of something else. The biopsy is, well, we won't get into eye-watering details, but nobody wants to do it.
Yeah.
And so clinicians are looking for information to say, actually, I can put that man on a wait and see list. MPV, very important. Not relevant for kidney transplant, right? Kidney transplant, anywhere up to half of the kidneys of the implanted organs will have a rejection event. That's not failure, but it's an event. So you need to do something about it. And so what clinicians have been looking for is PPV. It's positive predictive value, which is you need to take action. So when I said that cell-free DNA is non-specific, they position themselves as a rule-out test. So MPV very high, PPV very, very low, and said, okay, you want to know that nothing's happening. But for a while now, that's been very criticized in the or challenged in the community to say, okay, but don't if you're telling me that nothing's happening, okay, but I can get that from the standard of care already to quite a high degree. I'm really looking for this PPV, and you can't tell me very much because you're non-specific. And that's why there's been this push into what we call the genomic classifiers. That's what we are, right? We're on genetics. Yeah. So our RNA signatures, and we have said that, it's a PPV story. And our performance was multiple times better than other people's.
Right.
Let's put
okay.
it that way. And so when we talked about that, we said this is significantly better, and it is.
So Sarah, it's a rule in. What you've got is a very good or better than standard care rule in test. So it's going to tell a doctor, actually, it looks as though the acceptance is not great, and there's a potential here that is going to cause damage. So that gives them something to do. Something that they can do.
Test, right? You've got to take action.
Yeah.
You need to know whether you've got to take action or not.
Yeah.
And so does your patient, by the way, because these drugs are not, they're not like drugs. It's not like taking an aspirin and go to bed.
I mean, with COVID, I can understand it if you're suppressing
right.
people's immune response.
Right, very scary.
Yeah.
And steroids, and everybody knows what the story about steroids and other therapeutics. There's a value equation that's really important here. If you're going to take these drugs, you need to know it's worthwhile. You need to know your body wouldn't have done it in the first place. You need to know that the clinician needs to take action. You need to know that you have to act before you really damage and lose your graft. All of those are very actionable. And we're in an environment where you know that you've got at least a 1 in 2 chance that you're going to have to take action. So that's what's needed. You just don't need the MPV story. And in fact, actually serum creatinine does very well on that. So that's the standard of care. And so the comment has been, and the level of the pricing has also been that other tests, I've heard many clinicians say, well, I might as well do the biopsy because I get more information for it. Here, I will share with you some early information that was incredibly exciting that we did present in the poster, and will warrant further further studies. But we had a number of patients that had 2 biopsies for various reasons. Usually one is under a protocol and the other one's for cause. There's something dodgy going on here. And we had a number of them where the results were different on the biopsies. And the proof of the pudding is, in the majority of the case, the corresponding results moved as well. So when I say that these are real time and dynamic, on the same patient, if it was no rejection, it had a low result. And if it was a rejection event, it had a high result in the majority. No, not all. We're not perfect. No test is. But this was incredibly exciting to the clinical community for 2 reasons. One, it's kind of proof of the pudding that it works and it's dynamic. That's what we said. We saw the results, but when you see it like this, it becomes really compelling. And then the second thing is, we've always said that we're interested in monitoring, that it's not just a one and done test. All of our strategies behind that. We said we'll launch it with the data at one point in time, and then we will continue to study so that in time we can have these monitoring claims. And this was the very early look-see to see, yes, it works on a longitudinal basis. And I think no one's seen anything like that. And again, I will emphasize that when we were at the conference, we had a high degree of interest in this presentation and a lot of excitement.
Yeah, so just on that one, the American sort of Transplant Conference, etc. In terms of the doctors, then, they must be pretty excited. I would have thought, if it's got a PPV of sort of like multiples more than the sort of the standard of care currently. They must be thinking, crikey, this is it means we may not have to do any more. On the predictive side, we may do less biopsies. That's for sure.
I'll tell you what they were really excited about, and that is the way we did the study to get that result. So it's a twofer, right? The first one was everyone kept talking about the clinical design. And you think to yourself, well, what do you mean by that? Well, it was up to FDA standards. And what we did is with algorithms, quite often they'll mix in the discovery set with the validation. We don't believe in that. We believe in totally independent. So very independent. It was an international trial over 13 or 14 centers. And the importance of that is it goes across multiple protocols. Our exclusion criteria was very, very light. So we have what we call an all comers. And the reason why that's really important is because that's clinical reality. And when you do your discovery set, you kind of have very controlled environment. You're in your lab, kind of what you're looking at. For example, looking at a high risk group, you kind of know that you're going to get a top line flashy number, right? And everyone goes, great and all, but what am I going to see in my clinic? And so that's why we went on to do it. We could have launched, as many of our competitors have, on that kind of very controlled environment, a little bit subsection, I'm going to exclude this, and that's a bit confusing, so I'll ignore that kind of trial design. But that's not a validation trial that clinicians can really trust and lean into. what they are looking for is something that they can go, well, I don't need to do any further work. I know what's going to happen in my clinic because I get all sorts in my clinic and it's not a controlled environment, right? And so, you know, we knew that you kind of take a hit on that because, you know, in a controlled environment, I can give really sort of, you know, very high level results. But what happens in a all comers environment, you know, it's
the real world,
but it's going to be real. And that's crucial. And so there was quite a lot of buzz, and it was independently referenced to in many meetings that got reported back to me. So I wasn't there. But that study design caused quite a buzz. You know, it's what people have been asking for. That's what they say is a properly validated biomarker. And I think that is our first competitive advantage. Does it give me high flashy numbers? No. But is it still really exciting to the clinical community? And they'd rather have something slightly lower that they can trust, they can lean into, and they know what it is. They don't have to do any further work. We've done it for them. Yeah. Right. And well, then the second one,
go on.
Yeah, and then the second one was around the results as well. And most people were extraordinarily pleased by how high that PPV figure was. We have not seen anything else like it in the industry. And it pulls our test significantly ahead of the competition. And I know that there was a lot of excitement about that and looking for, everyone keeps saying, okay, so when can I have it in the clinic? Are you moving into commercial? So I was like, funny you should say that. Here's my commercial team. We've just launched, so very exciting.
Okay, well, big congrats on that. Now, also just the sort of the next steps in terms of the other two tests, but particularly the one, the Clarava with the prognosis, effectively the
pre-transplant,
the pre-transplant test, and how that, once you've actually developed that full suite of tests, how that improves the overall information to the clinician and therefore the accuracy of all the potential tests that give you more actionable data. And also I know you've talked about it before in terms of, you know, the extra data you're getting, you're collecting, you should presumably give you even better ways of improving the, you know, not only the suite of tests, but the individual tests as well.
Yeah, absolutely. So this is the point where Clarava and Tuteva, I've always said, will start diverging, right? Because Clarava is still a novel test. We're still waiting for some of the data to be put in from some of the sites. That's it's basically HLA. It's about the matching between the patient and the organ, which is important for the discrimination of the test. So we're waiting for that to be complete. We're about halfway there.
It's an industry first, isn't it, Sarah?
Yeah, it is. So, you know, in a couple of weeks' time, let's see how that comes when we unblind that. And, you know, but because it's an industry first, that's a good news, bad news story. The good news is we've got no competition. The bar is very low because they've got nothing. And so any information. The bad news is then I have to go off and do utility studies. So that's what I mean. We start off with the diversion. Tuteva, commercial launch, Clarava, and I'll try and do some of those in the real world in capacity, but effectively you have to kind of make this whole case about it's useful, the clinical utility. And that's where we're off to next with Clarava. Protega is that long stage damage. So we're still collecting patients for that. And we have not closed the clinical trial yet because it's for all three products. Again, good news for us because what we recognized was by that had to be powered to a higher level by an order of 3 or 4 times. So we had to collect more patients. But the good news for us is that adds more patient population and information to the first 2 tests. We cut off for the validation, but we're already collecting information for, you know, adding to that information, making bigger and bigger. We've already got one of the biggest validation studies, you know, or studies in the industry with this set, but we can add to it and we'll keep on adding to it. And as you said, that you know, in machine learning, and by the way, there is a difference. If people are used to machine learning algorithms in the financial world, that's going on all the time, right? Yeah. It's whirring in the background. Sometimes if something goes wrong, not to good effect. But in healthcare, you're not allowed to do that, right? You wouldn't do that continuous learning. So I always say it's like software updates, right? We collect the information, we rerun it, we see if there's any tweaks that we need to make. and then you issue the next version. But it is a bit like software updates. But I don't want everyone to think, oh, well, then you should just wait for, the new and improved version. This is a bit like, I always liken it like the iPhone story, right? We've got the iPhone, we're doing the launch. And if someone was waiting for that camera increase for the iPhone 10, great and all, but that's a long, that's in the future, and it would stop them having an iPhone today. So when we look at Tuteva, we went out there and said, and the clinical community said it's ready, it's useful now. Will it get better in the future? Yeah, sure. It'll be enhanced, but nobody's waiting for that. It's just an added benefit for the future. So I think that's really important. Now, you talked about the connections between all three tests. That's why we wanted to do one clinical trial and then hoik off the first two products and keep it open for Protega. We know that they inform each other. They're all on essentially the same platform. We're launching as individual tests, but we know that the power of this is the Verici solution in the future, that each part of that test becomes part of a platform play, a solution play for that clinician. And we'll be looking for other sort of bits and pieces that we can bolt on so that it becomes the go-to place for kidney transplant diagnostics.
Brilliant. And just for investors' knowledge, you mentioned on the Clarava that you've done the validation trial. Effectively, the results will be out, fairly soon. What's the difference between the validation results and the information they get out of and the utility test?
So one says, does this perform in the clinic as if you like, a scientific test, as a real diagnostic? So it's about the performance and picking up, and it's against a comparator, right? So we use the biopsy. It's quite a high level of comparison to make sure that we were doing well. And then a utility test asks a very different question. It says, okay, well, we assume that performance is right because you validated it, check. But is it useful in the clinic? Does it change clinical behavior? And that's why we don't need to do it in Tuteva, because they know already in that environment, clinicians will find it useful. So we don't have to, state the obvious. And we know that if they got the right information, they will change the level of medication. So nobody's asking us to reprove that. So, we'll do more longitudinal studies or monitoring or things like that, something that's a bit more novel and useful to the industry. Clarava, they don't know. I think it's obvious, but most clinicians think it's obvious, but you still have to prove it. And, getting that information right up front, we believe will affect clinical decision-making and improve patient outcomes, but we have to prove that.
Right, through a utilities to further utility.
That's right. That's the utility, really referencing, is it clinically useful?
Yeah. Okay. So obviously we've got the Tuteva going to be launched, or it is already launched, and you've got demand through from the sort of like the American Transplant Conference. What is the commercialization strategy of that, and obviously the all the full suite? Just sort of indicative timescales.
Yeah, I mean, I've always said that this year would be what I call commercial proof of concept. It's where you get together with some early adopters and learn how to really implement it in a hospital system. We know it has to be in the, they've got most people use Epic, right? How do I find the field? How do I train the transplant nurse to order it? Where's the easy button? If you remember the Staples advertising, slam on the easy button. You need to make the test easy. We were sat in a clinic and someone was talking about one of our competitors who spent quite a lot of money on their marketing budget. And the clinician said, oh yeah, I'd like to use it, but I've no idea how to order it. And I just wrote on a big note to easy. It has to be easy. If you can't order it, if you don't know how to order it, you're not going to order it. So, and the other part of it is we've done this validation. It is trusted, but not as much as clinicians telling other clinicians. So you want to get it into some centers, they use it, it performs well, they can talk about it, and that's how you roll it out. So I suppose it's like a beta test, right? But it's with a finished product. But it's, how do we get this on the easy path, easy ordering path, and how do other clinicians go out and talk about it on our behalf, because that's way more compelling. So next year would be, okay, then we're really going to go for, straightforward commercial sales. And that's where we'll start talking about revenues rather than numbers of centres.
And will that involve much more sort of investment in headcount or sort of like marketing?
Marketing for sure, but we're doing quite a lot of that already. I brought on the team. I'm looking to add a few more people, but that's it. You know, and we'll go out there and, you know, I'm a huge fan of saying, I think I know how to sell it, but we won't know until we're there, right?
Yeah, okay.
And you kind of want to go out and make sure you've got all your messaging right, that it's bang on, it's effective, you know how to talk to people before you do a kind of big expansion. And that's part of this this next year. So I think, you know, ultimately, we've always said that this is, you know, this is quite a limited touch point. There's only about 230, but probably only want to touch 180 of those transplant centers, you know, with any significant numbers in the US. That is not a huge sales force, which is great.
Yeah, okay. And what about after it sort of like hit the ground running in the US? What about in the international rollout? I mean, we've got kidney donor problems in in Europe as well.
Yeah, we're already looking with one eye on Europe and trying to figure out how you sell it. You know, Europe's a tricky place. Multiple, you know, it's supposed to be one center, but it's not. It's not like the States with the multiple states. It's lots of, you know, quarrelsome, you know, individualistic companies. And, you know, I'm British, so I always think, oh, let's go and launch with the NHS. Well, I know I've done that before and it's not as easy as you might think.
Yeah.
So we've got one eye on it and I'm busy figuring out all the bits and pieces that we need. And the first thing we needed was those European sites in the validation. You know, you need those local KOLs. You know, we've got 6 sites across Europe. So that was incredibly helpful, and some, you know, leading voices in there. Actually, I'm off to a European conference and sort of to chat to the European market next week. So, you know, this is something that we always keep an eye on.
Brilliant. Okay. Well, what's the, just finally then? What's the sort of the news flow going forward? I'm guessing it's going to be, you know, first and foremost is the results of Clarava probably sometime over the next month or so.
Yeah, you know, maybe not news flow, but people should be aware. You know, we submitted our file into the pricing committee for, you know, which is on time, which is, you know, something that's out there. They meet for their first meeting is on the 23rd, and then they have you know, different meetings, and then by the end of the year they'll give us some information on that. After that, we're already preparing the file for Tuteva for our application under the local coverage determination, basically a checklist saying, yes, we comply with all the requirements, and we'll do that. So, you know, that'll take a few months to consider, and then that will come through. So probably, you know, those sort of things more geared towards where we're working on them, but, you know, towards the end of the year for announcements. In the meantime, you can probably see us sort of go to conferences, start getting the word out, you know, maybe adding to the commercial team, and very much, you know, if we hit a critical number, which we should do shortly, I think I'm going to expand the number of patients in that study, because we had a high wastage percentage because of COVID, you know, people not coming back. I understand that. So we'll expand that, and then we'll close down the patient accrual and just be following them. And then obviously the work we're doing on the research asset and, you know, our partnerships, but there's a lot going on, and, you know, we'll roll out over the next 6 months.
And the value of that research asset, obviously the big biobank, which has got obviously all the RNA and the immuno profiles, etc.
Yeah.
Just in what areas, just top level, would you be looking to sort of like use that in, as not yourself, but sell it to partners, people to license that really valuable data?
Yeah, I mean, we would use it ourselves because it accelerates our own research, and there may be, you know, non-competitive other diagnostic companies. We do have a stated aim of sort of progressing the whole industry. But I think the most interesting thing really would be drug development companies. You know, to me, the most, I don't know whether you remember the KRAS story all those years ago, I'm kind of showing my age, but where they actually showed it was a colon cancer drug, and they showed that it didn't work in 1/3 of patients, and it was because of the mechanism.
Yeah.
So they had to launch it with this companion diagnostic to stratify that. If you're in that third, don't bother taking the drug, right? Nasty drug with lots of side effects. Yeah, it's got to be worth it. If you're in the 2/3, it's totally worth it, right? So that was the kind of stratification. But of course, it affects their results. And we know that there's not an awful lot of stratification going on in transplant. There's not been that information. Of course, we have that information. And I think that that's going to be very valuable in terms of drug development. And as a diagnostic company, we want to support that. You always are only as good as your so what answer, right? You've got this information, so what? Well, you know, we aim to promote increased care in there and increase our so what answer. So I can see a lot of collaboration there, and I think the there's been a couple of things that I have wondered if have stalled because they didn't have the stratification there. So we'll see. I think there'll be a lot of interest there.
Brilliant. Well, that's going to keep you busy there, Sarah, and your team. So I look forward to hearing the news flow. So thanks very much for your time, and look forward in touching base shortly. So take care.
Great chat. All right. Thanks. Bye.